Hello and welcome back to Chapter 3, Lifting and Moving Patients. So obviously we do not want to do that with our patients. Um, so we're going to talk about topics. We're going to talk about body mechanics and the different kinds of moves that we'll use in EMS. And obviously I can't go over every single move because every move is different and every patient is different. So let's talk about body mechanics first off. So it is the proper use of your body to prevent injury and to facilitate moving facilitate lifting and moving. Um, on your screen there, you've got some different positions that you'll actually learn in Chapter 5 a little bit. But when we talk about lifting and moving and transferring patients, we kind of need to know what these things are. So high Fowler's is basically where this patient is sitting on the cot, legs up, and they're sitting up. Trendelenburg, this is where the feet are elevated above the heart. Prone is where the patient is on their stomach. Supine is where they're on their back, and then low Fowler's is elevated at about a 30 degree angle, still laying on the cot. So we want to consider the following before lifting any patient. So we want to know what the object is, its weight, and whether it would require additional personnel to lift other than what you've got. Your limitations, what is your physical condition and characteristics, and then communication. Make a plan and communicate with your partner. Don't just assume that your partner is going to know what you want to do. You have to make a plan, you have to communicate it and talk about it because they may have an idea that says, hey, maybe we could do it this way and it might be better. Okay. So rules for lifting, you're going to position your feet properly, use your legs, never turn or twist, do not compensate when lifting with one hand, keep the weight as close to your body as possible, use a stair chair when carrying a patient on stairs or whenever possible. So there's a couple different things. There's the power lift where your hands are facing outwards, gripping whatever you've got, like the cot. Hands are facing outwards, knees slightly bent, and then you're going to lift. The power grip is that hands facing outwards, gripping whatever you've got. If you grip like that, you have much more strength to grip and hold than you do if you grip the other way. When reaching, keep your back in a locked position. Avoid twisting while reaching. Avoid reaching more than 20 inches in front of your body. And avoid prolonged reaching when strenuous effort is required. When pushing or pulling, push rather than pull. Keep back locked in. Keep line of pull through the center of the body. And keep the weight close to your body. If the weight is below your waist, push or pull from a kneeling position. Avoid pushing or pulling overhead and keep your elbows bent and arms close to your sides. All right, so let's talk about some moves. So emergency moves. This is when these are used when the scene is hazardous, care of life-threatening conditions requires repositioning, or you must reach other patients. These include closed drags, incline drags, where you are lifting underneath the shoulders and dragging the feet down the stairs rather than dragging the head down the stairs. I know it sounds fun, but it's probably not a good idea. The firefighter drag, the blanket drag, and then the assisted carries up here at the top. Urgent moves. So situations where you would use these is that they require treatment, that the required treatment can only be performed if the patient is moved, and factors at the scene cause patient decline. Usually involves moving the patient to a backboard. Okay, not emergent moves. So these are not an immediate life threat. The patient can be assessed, treated, and moved in a normal way, and take all required precautions not to aggravate any kind of existing conditions. So let's talk about patient carrying devices. Stretchers or any other device designed to carry the patient safely to the ambulance and or to the hospital. Wheeled stretchers, you've got power stretchers, manual stretchers, bariatric stretchers. Some are rated to carry patients weighing 800 pounds or more. Okay, so up here down here at the bottom, the Stryker, the yellow Stryker cot, you've got that is an electric cot. These are both electric actually, and they lift and lower with the touch of a button. The difference here is that the Stryker is an X-frame and the Furno is a modified H-frame. So what happens is the back legs, you put the cot in the ambulance, the back legs raises up, you push in farther, and then the front legs raise up. This down here in the bottom is a bariatric setup, and it has a winch in there that they are using to winch that patient up with the ramps. Stair chairs. These are useful where stretchers cannot be easily maneuvered. Here at the lake, we have a lot of condominiums, and stair chairs are our friends because you cannot get a cot up there, and sometimes there is no elevator as well. And even if there is an elevator, it is a very small elevator. Spine boards. They can be short or long. Short is rarely used in EMS practice. Long is rarely used in EMS practice as well. We use them now more for just getting the patient out of the cot or out of the situation that they're in and taking them to the cot and then taking the backboard off of them. We do not any longer transport patients on a backboard. So stair chair there on the left. And this one actually has the tracks that fold out, and you can just basically slide the stair chair down the stairs. And then you've got this long backboards, and then a short board or KED. So carrying devices. So other types of stretchers, we've got portable stretchers, scoop stretchers, basket stretchers, flexible stretchers, Stokes baskets, air mattresses, all sorts of different types of things. Mainly, we on the ambulance, out of all of the 5 up there, we only carry the 1. We used to carry the air mattresses where basically you put the patient on it and then you suck the air out of the air mattress, and then it's like a bean bag, and you suck all the air out, and these beads would form around the patient. Patients with suspected spinal injuries, we want to immobilize the head, neck, and spine before moving, perform manual stabilization, and place a rigid collar, and then restrict movement of the neck and spine. Again, we're not transporting on a backboard. All we're doing is placing a C-collar and moving them. The patient can basically self-splint. If their back is hurting and it's injured, they're probably not going to move it a whole lot. Patients with no suspected spinal injury, so extremity lifts. This is used to carry the patient to the stretcher or stair chair. It can be used to lift the patient from the ground or from a sitting position. Okay, so moving patients onto carrying devices. Again, patients with no suspected spinal injury, we want to use a direct ground lift, lifting from the ground to the stretcher. And these pictures are not realistic. The only reason I include these pictures is because I want to show you that it's not realistic. You can't do this because this patient here is absolutely rigid. Like, she is just rigid and she's not moving. It's easy to pick her up, but it's not going to be that way every time. They're going to be like a floppy fish flopping around on the ground and in your arms. So this is not going to work. I'll show you. I think I've got a couple more slides down the way to do it. Okay. Patient with no suspected spinal injury, a draw sheet method or a direct carry method. The draw sheet method really, the issue with this is that this cot or this hospital bed can move. This cot can move. So what we do is one person is on one side, the other person is on the other side. One person pushes and the other person pulls. Recovery position. So the recovery position, this is where the patient is laying on their left side, preferably arm up underneath their head. More so I would want their chin to kind of be at their elbow, if you can, or down, so that way their head is facing downwards instead of the way it is right there. Yeah. So patient positioning, position for shock. Place the patients believed to be in shock in a supine position. Do not lower the head and do not raise the legs. We used to do a shock position where it was Trendelenburg, essentially, where we raised the feet up above the heart to try and get blood to go back to the heart and circulating in the core. However, again, research, evidence-based guidelines have said, hey, that's not the best way to do it. Transferring the patient to a hospital stretcher. When you arrive at the hospital, you will move the patient from the ambulance stretcher to the hospital stretcher using a modified draw sheet method. Again, this is what I was saying, from going from hospital bed to the cot or cot to the hospital bed. You know, have people on each side of the beds to stabilize the beds so that they're not going to move. People push and somebody pulls. And that makes it 10 times easier on all of that. So questions to consider. Why are body mechanics so important when lifting and moving patients? Why is using the appropriate patient carrying device an important consideration? And would an emergency move be necessary? And in what ways can proper positioning help a patient's condition? Okay, so just ask yourself those questions. Again, it's a short lecture here, but just remember that you've got the power grip, the power lift, using the proper body mechanics to make sure that you're not going to get injured, and patient lifting, making sure that you've got a plan when you go to lift a patient, so that way you're not going to injure yourself or the patient, and various other things. You've got to make sure that you know what you're going to do, how you're going to do it, when you're going to do it, and that you can, call a timeout if you need to. Maybe reconsider how you're going to lift a patient. Typically, we go and we lift patients up off the floor. There are devices that assist in lifting those patients up off the floor, such as like SAM splints. Or I'm not sorry, not SAM splints, but Samson straps. They are just straps with handles. There's also the bender lift. Looks like that KED that I showed you, but it doesn't have the rigid back or neck support. But it's got a bunch of handles around the waist to help facilitate the lifting of that patient. And everybody has their own preferred way of lifting patients. There's not necessarily one wrong way to lift a patient. It just kind of depends, and it depends on the patient's injuries, if they have any injuries, or if they've got the ability to stand or not. So yeah, been chapter 3, lifting and moving patients. So the end of this, you'll have your 10 questions to go over. If you don't, then don't do them.